Good afternoon, everyone, and welcome to the CDC's Hemoglobinopathy webinar series. I'm Shay Pope from the Division of Blood Disorders, and I'll be serving as today's moderator. But before we start the presentation, I'll go over a few points. As the conference leader, I've muted all the conference lines to eliminate background noise. After the presentation, we will allow questions, and you'll have to press *6 to individually unmute your line at that time. Since we can't actually see who wishes to make a comment, please electronically raise your hand if you wish to speak. To raise your hand, you'll click on the Q&A tab on the menu bar of your webinar screen. In the Q&A window, click on the hand icon in the upper right-hand corner. This will display your name to the meeting presenters, and I'll call on participants as their names are displayed. You can raise your hand during the presentation, but we will wait until the discussion period to address those comments. Also, this session is being recorded. Today's topic is strategies from the field, data collection and harmonization. Our presenters represent the 7 states from the RusH pilot project, each of which will introduce themselves shortly. So our presentation features a document recently published called RusH Strategies from the Field Data Collection, and this publication is the second of 2 documents, the first of which was featured on health promotion. You can find the webinar slides from the health promotion presentation archived on seinfo.org, and both publications can be downloaded from the Division of Blood Disorders website. So today we're going to provide a brief overview of the RusH project and how the strategies document was designed. Then you'll hear from each of the 7 RusH states as they describe their contribution to this publication. So remember to please hold your questions until the end of the presentations. Contact information will be listed at the end slide of each presentation in the event that you want to follow up with the states individually. The Registry and Surveillance System for Hemoglobinopathies, RusH, is a 7-state, 2-year pilot program that aims to systematically collect surveillance data on sickle cell disease and thalassemia in the United States. And you can read more about the RusH project via the website that's listed there on the slide. The primary focus of the strategies document is to share the unique implementation of activities that assist in meeting the RusH programmatic goals. Each state highlighted one activity for this publication, but all states had multiple activities that contributed to their ability to collect and harmonize data. Some potential uses of the strategies document may be to impact public health policy, allocation of resources, speaking out on critical issues, and initiating public discussion on hemoglobinopathies. To achieve the RusH project objectives, 3 work groups were developed. Data collection and harmonization was 1, surveillance and design, as well as community partnership and health education. And today we're introducing and reviewing the publication that was produced for the data collection and harmonization work group. The content in this publication is categorized as follows. Each starts with a program overview, which highlights the goals and gives a brief description. Then it's followed by resources that are needed to carry out this activity, such as logistics, partners, tools, etc. Then we also describe the benefits from the activity, as well as outcomes for potential policy, education, data quality, and patients. And then we also have lessons learned from planning to implementation, as well as next steps and acknowledgments. So at this time, I'd like to introduce Lisa Feuchtbaum from California. She'll be presenting obtaining and using Medicaid data for hemoglobinopathy surveillance. And Lisa, at this time, if you could press *6 to unmute your line, and you can address the audience. Lisa, are you there?
Can you hear me?
I can hear you now, yes.
Very nice. Thank you.
Yes, I'm here. I'm sorry.
Okay.
I'm sorry, for Lisa Feuchtbaum.
So my name, again, is Lisa Feuchtbaum, as Shay just noted, and I'm the principal investigator of the RusH project in California. And can we go to the first slide, please? Thank you. So as part of our surveillance effort to find as many individuals as possible with sickle cell disease and thalassemia in California, we relied on many sources of data, each with unique pros and cons. This presentation will discuss our experience working with data from the Medicaid program in California, which in our state is referred to as the Medi-Cal program. As you can see, in addition to the medical data, we were also able to obtain patient-level data with identifiers from the newborn screening program, hospital discharge data, emergency room data, vital statistics data, including both the birth and death files, and clinic data from two large programs in the state at Children's Hospital Los Angeles and Children's Hospital Research Center in Oakland. So obtaining the actual data sets from these agencies was our first major hurdle, but even more challenging was the linkage and deduplication of individuals within and across data sets that was necessary to achieve our surveillance goal. With respect to sickle cell disease, which will be the focus of this presentation, we were able to identify over 5,800 unique individuals that had either confirmed or probable diagnosis of sickle cell disease, using the common agreed-upon definitions developed by the multi-state collaborative. We found that among all data sources, the Medi-Cal data set contributed the largest share of sickle cell disease cases found, and the Medi-Cal data set was also the only source for prescription drug claim information, outpatient visit data, provider information, and some cost information. Next slide. So as far as key resources needed to obtain the Medi-Cal data, first we needed to obtain an IRB exemption from the California Committee for the Protection of Human Subjects. Since the activities were not considered research and in fact were considered surveillance, we actually didn't have any contact with human subjects. Second, the Medi-Cal program required an additional review process by their own data and research committee. And at the completion of the negotiation process with Medi-Cal, which took over 10 months to complete, we did receive all records for any patients that had relevant ICD-9 codes for sickle cell disease or thalassemia in the data set going back to the year 2000. As far as lessons learned, next slide, the Medi-Cal data is not collected for the purpose of public health surveillance. So coding and dates and data dictionaries were not entirely clear at the outset. For example, 5 different coding systems were used throughout the data set and sometimes within the same data field. So in addition to ICD-9 procedure codes, we had to sort through HIC codes and PT codes, which required someone that had knowledge of these coding systems. Also, there were multiple billing lines for each visit or event, and this required us to deduplicate this information so the visits and events were not counted more than once. And in addition, some counties used different identifiers for different periods of time. So the Social Security number was not the only identifier used. And lastly, at the start of the project, we did not request the Medi-Cal eligibility data for our study period, and at the time we were not aware that this was even available. So when trying to track healthcare utilization over time, for example, prescriptions for hydroxyurea, it was not clear when people were definitively enrolled in Medi-Cal and not using services versus not being enrolled in Medi-Cal for any given stretch of time. Next slide. So in summary, some of the challenges we faced when using the Medi-Cal data set were that it was first difficult to obtain, and the information contained was not meant for surveillance. It required a high level of data cleaning and a long learning curve to understand how it could be used. We were also able to find a large number of unique cases that weren't found in any other data source. Another pro was that it was a robust data system that did include information on prescription drug claims, outpatient visits, provider information, and some cost information. And in the end, over 50% of identified cases were found in the Medi-Cal data set. And I'll show you a slide that gives you just a little bit more detail on that. And in terms of sustainability and translation, we are one of the states that receive additional funding from the CDC to conduct a validation study of the data that was collected during the RusH phase of the project and continued dissemination of findings. Next slide. So this table shows the contribution of each data source to the case finding effort. The first column shows the number of unique cases found within each data source, and the second column shows the count of unique cases that were not found in any other data source. And as you can see, there were 543 individuals in the Medi-Cal data source that were not identified anywhere else. Next slide. So I want to acknowledge Susan Poliakonis, our project director, who, among other things, oversaw the work of our data analyst, William Harris, who was engaged in the data set analyses, including the deduplication and linkage of the data sources. Again, not a trivial task. And I encourage you to visit the California Sickle Cell Resource website. The link is shown on the slide, which contains important information on sickle cell disease for patients and providers in California, and where we will be disseminating many of our RusH findings in the next phase of our project. So thank you very much for your attention, and I'll turn the presentation back to Shay.
Great. Thank you so much, Lisa. Now we have Robin Stottlemyre, who will present Michigan's hemoglobinopathy follow-up module. Robin, at this time, can you press *6 to unmute your line, and you can go ahead and address the audience.
All right, Shay, am I here?
Yes, you are.
Excellent. Go ahead, next slide, please. All right, so hi, everyone. This is Robin Stottlemyre. Some of you may formerly know me as Robin O'Neill. I'm the Michigan Hemoglobinopathy Surveillance Quality Improvement Program Coordinator, and I work in the newborn screening follow-up here at the Michigan Department of Community Health. I'll be taking you through a quick trip of Michigan's recent successes in constructing a web-based module for monitoring all newborn screening follow-up for children with hemoglobinopathies, which is part of Michigan's RusH project. The Michigan Care Improvement Registry, which we call MICR, is a system used to track immunizations throughout the state, and recently it's been expanded to include other disorders as well. Our sickle cell module was one of the first ones, so it was really a trailblazer that ended up paving the way for a lot of other similar modules within the MICR application. Since 2007, Michigan's birth records have been linked to newborn screening records in order to identify potentially unscreened infants. And these linked records are uploaded weekly to the MICR and also to our hemoglobinopathy follow module, which is routinely populated automatically with all the kids who have abnormal results. So in other words, all newborn screening cases have their MICR profile added to the hemoglobinopathy follow-up roster, which where each one of them is assigned to a regional patient advocate based on their home address zip code. In order for all this to happen, a state needs to have a staff with technical expertise to conduct these linkages and strong relationships and collaboration between newborn screening and vital records, as well as with the In the Trenches community-based follow-up organization, which for us was the Sickle Cell Disease Association of America Michigan chapter. The follow-up duties were integrated into the module based on the already established follow-up protocols from the SCDA-MI, which is the Sickle Cell Center. Basically, the patient advocates are responsible for documenting the penicillin start date, the confirmatory test results, all the education activities completed with the sickle cell client and their family, and any other interaction that goes on. Patient advocates are also responsible for conducting a health status assessment on the child. Michigan is really fortunate to have a very active hemoglobinopathy advisory committee with many of the state's pediatric and adult hematologists, along with other representatives from health plans and state public health and the SCDA Michigan chapter. This advisory committee has been a tremendous resource in making key decisions about follow-up protocols and decisions regarding Michigan's comprehensive health status assessment. So we're really happy to have them, and we hope that they will continue to be supportive in the future. This project has definitely encountered its share of barriers and lessons learned, with the most recent being accessibility of the module among program staff and sustainability of the staff time and funds. So building a module like our sickle cell MICR application is very expensive, but it's also very expensive to maintain. And in the future, we hope to develop further reports within the application that will develop quality improvement and provide a more programmatic service for the sickle cell staff themselves. Right now, they're doing it more as a surveillance system entering into Michigan, and we hope to make it more of a resource for them as well. Hopefully, our improvements will lead to a more complete and accurate documentation of the follow-up activities done here in Michigan. Next slide, please. The regional patient advocates working for the Sickle Cell Disease Association of America, Michigan chapter have been documenting their follow-up activities for the clients in MICR for almost 2 years. And now that we're expanding the module with a revised health status assessment, this includes self-reported data for sickle cell disease patients of all ages. Michigan newborn screening follow-up is committed to seeing this project through and making sure that it doesn't fizzle out once RusH funding has ended. So by using alternative funded sources such as the AHRQ grant, which we have collaborated with through the University of Michigan, the newborn screening program hopes to build off what we already have been accomplished to further develop this module and monitor data entry in the coming years. Slide, please. So that is it for Michigan, one part of our RusH program here. And if you have any questions, you can contact me, Robin Stottlemyer, or Bill Young, who is the PI for Michigan. Thank you.
Great. Thank you, Robin. Now we'll have Amanda Cuffs from New York, who will be presenting, let's see, case ascertainment of individuals with hemoglobinopathies not identified through newborn screening. Amanda, if you could press star 6 and address the audience. Amanda, you there?
Can you hear me okay?
Yes, now we can.
All right. Hello, everybody. My name is Amanda Cuffs. I'm an assistant research scientist with the New York State Department of Health, and I work extensively with clinical data collection on the RusH project. So I'll go into an overview of that for you. As a result of newborn screening, all babies born in New York State since 1975 have been screened for hemoglobinopathies. However, while this catches a significant portion of New York State cases, it does not provide a complete count of all individuals living in the state. For example, newborn screening does not account for those individuals who were born in another country, in another state, or before 1975. In order to make a more accurate count, we need to look beyond newborn screening at clinical cases of patients being seen and treated at centers around the state. Thus, at the outset of clinical data collection for the project, letters were sent to providers at pediatric hemoglobinopathy specialty care centers, informing them about the RusH project and asking for them to participate in clinical data review of any patients being seen and treated at their centers during the project period. Due to HIPAA privacy laws, all RusH project tasks concerning collection of personally identifiable information were subject to review and approval by each institution's institutional review board. All right, next slide. Once we began working with centers on data collection processes, it became clear that labor shortage was a common hurdle to overcome when working through the steps of case identification, record review, and extraction of key data elements at each respective center. This is a very time-consuming process that hospital staff often do not have room for in addition to their normal job responsibilities. As a result of this, RusH staff tried their best to work with staff at each center to decrease the burden of these tasks as much as possible. We had RusH staff dedicated to communicating with centers who would distribute key project documents, assist with IRB applications and questions posed by IRB panelists, and follow up with center progress on a regular basis. In addition, RusH staffers also performed several site visits to centers to perform record review and data extraction. As such, another important resource was adequate funding to support travel for several days at a time. Another important resource we drew upon was software that was capable of keeping the several hundred cases we accumulated organized and navigable. We developed a data collection tool using MS Access to accomplish this task, which organized patient cases into their demographic, diagnosis, and treatment subcategories. All right, next slide. The greatest lesson learned as a result of the project is the outreach and data collection process requires a substantial time commitment, constant communication, and organization. And also, the institutional review board approval at each center is a key component to all of this. The criteria used for approval varies considerably among institutions. We had some institutions that are approved us relatively easily, and then there were others that we had to submit to multiple times, had to answer questions posed by the IRB or draft patient consent forms, etc. And this can add significantly to the project timeline and can also limit access to data in some cases. We actually had one center where we were granted access to just outpatient data as opposed to inpatient data, and that kind of thing is a possibility if the IRB makes that call. For For future projects, we recommend, first and foremost, obviously, careful attention to structuring the research design in compliance with privacy and HIPAA laws, as well as obtaining a legislative mandate if such is possible, especially in our case, a few months into clinical data outreach when we realized all of the issues inherent in the IRB approval process. The RusH project principal investigators sought a letter from the New York State Commissioner of Health granting them the authority to collect data on patients for the RusH project. As a result, an order was issued under Public Health Law 2061J in January of this year doing so. The letter was distributed to the specialty treatment centers with the aim of facilitating IRB approval at each institution. In any case, sufficient manpower and funding for work is necessary for the involvement in case identification, chart review, and data extraction. Next slide. The outcome of all this is that we have 8 centers that receive IRB approval and are actively working with us on data collection efforts. These are the New York Blood Center, the Bronx Lebanon Hospital Center, Brookdale University Hospital and Medical Center, Interfaith Medical Center, New York Methodist, New York Presbyterian, both Weill Cornell and Columbia campuses, as well as the Women and Children's Hospital of Buffalo. At each center, non-newborn screening cases were able to be identified, and the clinical data represented, which is over 500 cases, should shed light on the prevalence of hemoglobinopathies and the most common treatments administered to those patients. Next slide. At this point, the groundwork has been laid for continued communication and collaboration with treatment centers. The next logical step would be to reach out to adult hemoglobinopathy specialty treatment centers, which we've already done some work on to date. Earlier in the project, surveys were administered to providers at adult treatment centers to ascertain what kind of clinical information they were collecting. Outreach to those centers would follow the same protocol used in outreach to the pediatric centers. And since the document was first formalized, the New York Blood Center is our most recently approved institution, and that will provide a different data set from our other centers based on the fact that it is a blood collection and distribution organization rather than a traditional hospital treatment center, so they specialize in providing blood to patients that require transfusion, many of which are patients with hemoglobinopathy. To date, we have collected clinical data on over 500 cases, and we expect to collect several hundred more by the project's completion. All right, end slide. So we want to acknowledge our project PI, Yin Wang, who works for the Congenital Malformations Registry, and myself, Amanda Cuff. And at the bottom there is our New York State link to the RusH project through our Wadsworth Center, and that is the hub for our newborn screening program. Well, that's all from New York. Thank you.
Excellent. Thank you so much, Amanda. And now we'll have Ron Tringali from Pennsylvania to introduce the value of partnerships in creating a hemoglobinopathy database. So, Ron, you can address the audience at this time. Ron, if you make sure you press *6 to unmute your phone. Or maybe he's not on the line. Is anyone from Pennsylvania available? Okay, well, we're actually, we'll move on to North Carolina. We're just going to click through Pennsylvania slides momentarily. Yvonne Green.
Can you hear me?
Oh,
Shay?
I'm sorry, we can hear you now. Thank you. I'm sorry about that.
Thank you. We've been having a little bit of technical difficulties with our system here, so I apologize for the delay. So
oh, no problem at all. Thank you so much for joining us.
Okay, thank you. Again, I'm Ron Tringali, and I'm an epidemiologist with the Department of Health and was the epidemiologist for the RusH project for Pennsylvania. And I am going to present about our partnerships in creating a hemoglobinopathies database. The activity that we have engaged in was to develop a linked data surveillance system for sickle cell disease and thalassemia patients to aggregate descriptive data for specific populations. And what we did was, because of issues in terms of data collection, we partnered with 3 specific hospitals, that being the Children's Hospital of Philadelphia, Children's Hospital of Pittsburgh, St. Christopher's Hospital in Philadelphia, and we also work closely with Carnegie Mellon University, and we also brought in our database from our birth certificate vital statistics files. And the key resources that we found that we needed is that unique qualities that each of the data sources brought to the partnerships. And for Pennsylvania, that was the newborn screening database that we had here at in Pennsylvania. The hospital's wealth of data about sickle cell disease and thalassemia from the 3 children's hospitals, and Carnegie Mellon, the university's computer resource and de-identification technologies and data management and their linkage programs that were very vital to the success of our program. Next slide, please. One of the other issues that we were having some very significant issues with was the time and coordinating the process of creating the database required, which required frequent conference calls with the partners and time and dedication to the project beyond the patients and the usual duties of the clinical staff that we were working with, especially between the 3 hospitals. And we would also travel between Harrisburg and the different hospitals, especially also at Carnegie Mellon, to coordinate the data linkage. Lessons learned from our participation in the program was, as one of the other states mentioned, allow for plenty of time and flexibility to discuss and resolve any problems that arise in this process. Assembling the appropriate teams with expertise in the clinical domains, in epidemiology, public health, information technology as applied to healthcare data, and that's where Carnegie Mellon really played a vital role. And analytical capabilities and project management, and most importantly, the knowledge of and links to target communities of sickle cell disease patients is also essential to the success of such projects. The next slide, please. The outcomes from our project were the formation of a partnership that was integral in accomplishing the construction of a hemoglobin database containing data from the 3 separate treatment facilities and the Pennsylvania's Department of Health's newborn screening database, which was a great accomplishment for us. Participating in the process has provided us with as close to an accurate account of the population of persons living with sickle cell disease and thalassemia in Pennsylvania, service utilization of treatment centers, and the CBO resources involved in treating these patients. This provided a stronger foundation to assess resources needed for sickle cell and thalassemia population, and information can then be translated into actual dollars that can be used in a cost analysis for the identification and treatment of these patients. And finally, a better understanding of the data linkage methods and mechanisms that are needed to aggregate statewide data about services used and resources needed for specific diagnostic groups. And next slide, please. The sustainability and translation is for continued ongoing efforts to secure data user agreements between other necessary partners to enable the linkage of additional data sites. And through the establishment of these partnerships, hopefully this will serve as a model to expand the program to include other hospitals in Pennsylvania, as well as information on the adult population for sickle cell disease and thalassemia. And final slide. And again, our contact information is Will Kramer, who's Division Director for the newborn screening and the website is also listed at the bottom. Thank you very much.
Excellent. Thank you so much, Ron. Next, we're going to have Yvonne Green from North Carolina, and she will be presenting Matching Existing Government and Clinical Data Sets. Yvonne, if you can press *6 to unmute your line and address the audience.
Hi, good afternoon. My name is Yvonne Green. I work with the North Carolina Sickle Cell Syndrome Program within the Division of Public Health. And as Jay stated, my topic is matching government and clinical data sets. Next slide. The goal of the RusH project was to gather information on a number of people with sickle cell disease and thalassemia who received care and services in North Carolina in the years 2004 to 2008.
I'm sorry to interrupt you, Yvonne. We're having some trouble hearing you. Sounds like your phone's going in and out.
Oh, okay. Can you hear me better now?
A little bit. I don't know if it might be your speakerphone.
Okay. Its secondary goal was to determine what health services this population received during the same time frame. Each state health department in North Carolina routinely collects data that provides information about people who live in our state. Therefore, the North Carolina RusH project was designed to collect information on specific data sets from various governmental and clinical data sources. In addition, the gathered surveillance data would guide the health practices for program partners and healthcare professionals to better serve population affected by hemoglobinopathies. In order to conduct surveillance of people with hemoglobinopathies in North Carolina, it was important to determine the system within state government already in existence that could provide access to information on the targeted population and obtain legal access to these systems. Before embarking on the process of data collection activities,
it is also important to consider the key resources that are necessary and available. Therefore, one key resource needed to obtain the data is letter of agreements and memorandum of agreements from these various governmental agencies, clinical partners, and community entities, such as community-based organizations. Another resource is having suitable data programming staff, such as IT, programmers, coders, or data managers, etc., with particular skill sets and having the expertise in matching data sets. Also, there needs to be consideration for the availability of appropriate computer software and hardware such as SAS, SPSS, and Microsoft Excel to extract, deduplicate, and link large data sets. Next slide. There are some lessons learned from this project. For instance, there needs to be clearly defined goals and objectives at the beginning of the project to eliminate confusions. Changes can cause delay and affect the project expected timelines. There must be adequate time allowed so that all partners are able to agree on deliverables and clearly define the expectation for the work. As we know, competing agendas and issues can arise, which can challenge the prioritization of the surveillance activities. Another lesson learned is the possibility of substandard data may be delivered as a result requiring additional review, cleaning, and analysis. Validation of the quality of the data is definitely necessary. If only limited information is available from the data set requested from participating partners, this may inhibit the matching process among various data sets. Next slide. Upon matching these data sets, analysis of the data allow public health partners to have a better understanding of statewide prevalence and incident estimates of hemoglobinopathies, as well as the effect of these diseases specific to healthcare utilization. During the study period, we found that about 8,900 unique individuals identified with sickle cell disease or thalassemia who are living in North Carolina from 2004 to 2008 when merging all data sets, with roughly 50% confirmed cases, 14% false cases, 36% possible cases. In addition, the outcome of this project created a roadmap and model for accessing data and building interagency collaboration within state government. Data collection from this activity also provides opportunity for enhancement and evaluation of the North Carolina Sickle Cell Syndrome program, as well as track the trends of the effects of the condition and individuals throughout the lifespan. The North Carolina Sickle Cell Syndrome program is committed to the advancement in treatment, research, and quality of care of people with sickle cell disease and thalassemia. Some efforts will be continued beyond this RusH project, including sharing interagency data and building a statewide partnership. We will also link all hemoglobinopathy results from our North Carolina State Secretary of Public Health with our program web-based system, as well as the 6 comprehensive medical center reporting to our system for continued surveillance activities. Ongoing surveillance for hemoglobinopathies also is the basic public health activities for the North Carolina Sickle Cell Syndrome Program to ensure that the appropriate protocols, treatment, services, and prevention efforts are being met. Next slide. Currently, the North Carolina Sickle Cell Syndrome Program is working with UNC Greensboro to analyze the collected data, along with developing fact sheets for targeted areas for dissemination. Some activities related facts show that from 2004 to 2008, about 3,100 individuals seen in at least one of our 6 comprehensive medical centers. During that same time period, there were all 496 newborns screened for hemoglobinopathies, with 72% treated in one of our medical centers. And of those, 96% were identified with sickle cell disease and 88 were confirmed diagnoses. Overall, there were individuals overlapping in one of these data sets. For instance, in our precision medical care enrollees, the 496, of the 496, 81% overlap with hospital discharge or emergency department, and 70% in our 6 medical centers. In addition, of the 3,332 Medicaid enrollees identified, 96 overlap with hospital emergency room department files, or 50% in one of our six medical centers. Lastly, between 30% to 40% of the individuals identified with hemoglobinopathy to our hospital discharge and emergency discharge files all overlap in one clinical file. In summary, this surveillance activity in governmental and clinical data for hemoglobinopathies will help provide estimates for prevalence and incidence of our disease population in North Carolina, and can also be used to explore the validity of using administrative data from government agencies for further health research. Next slide. I would like to thank our PI, acknowledge our PI, Belinda Pettiford, and our co-PI, Joseph Telfair, and myself, and our RusH website is located on our state program, North Carolina Sickle Cell Syndrome Program.org. Thank you.
Thank you so much, Yvonne. Next, we'll have Brendan Noggle from the Georgia team, and he'll be presenting limitations of ICD codes for defining and identifying hemoglobinopathy cases.
Hi, thank you. Like she said, my name is Brendan Noggle. I'm an epidemiologist with the Maternal and Child Health section. Next slide, please. So, in case you're not familiar with ICD codes, so they were created, or I guess the first attempt at classifying diseases and deaths happened like in the 1700s, and then around 1890 or so, they had a WHO as their first list of causes of death. And these classifications focused mostly on deaths until about the turn of the 19th century, or 20th century, I guess 1900s or so. Then there was the first international classification of causes of sickness and death. And now we're up to the 9th revision of the ICD codes for morbidities and for mortality, the death. We typically use ICD-10 codes, the 10th revision. So there are many diseases out there, and there are just as many codes, almost. They're very specific sometimes, and other times they're not quite as specific as we like to accurately characterize a disease. So for surveillance purposes, I can see the use of ICD codes in 2 different ways. So one of the ways is to identify cases, and the other way is to use the codes to describe a clinical situation for a case that you've already identified. Along those lines, there's codes for comorbid conditions and treatments and medicines that help us add specificity to the case classification. So one of the things that's very important to actually getting the data, and you've heard this before on this call, is that you need partnerships and data sharing agreements. We've received our administrative data sets from our state insurance program, Medicaid, the Children's Health Insurance Program, or CHIP program, as well as the state health insurance program, too. So we have a good bit of information there, as well as from all hospital discharges and ER visits from our Georgia Hospital Association. So we had to have agreements with all of these organizations. The Hospital Association does a good job of standardizing all of the discharges and ICD codes for us. So as you can imagine, there are millions of records from each of these data sources. So you have to have an analyst comfortable and, I guess, a computer also, too, that's comfortable with handling all those data. Next slide, please. So some of the things we've learned, and you've heard this before, too, is that these records are used for billing and for, administrative purposes, not for surveillance. A lot of times, a physician is seeing what's going on with the case and to rule out diagnoses. That's going to be listed in there, and it could not. I mean, there's very easy for it not to be the final diagnosis. So, what that means is that a lot of times we need to look at multiple instances. So if it happens for an individual, if you see this code over and over again, it's going to make make us assume that more likely than not it's going to be an actual case. One of the things we found with other studies is that the sensitivity of hospital discharge data varies based on the seriousness of the condition, but also between different facilities too. So unfortunately, you can't just take the entire data set and treat it the same. There may be conditions or cases, scenarios where you may trust one source of data more than another. Also, case comparisons across data sets is limited because the coding varies. California mentioned this earlier too, is that certain ICD codes may show procedures, they may show diagnoses, other codes may show treatments. Next slide, please. Something else we learned is that that certain diseases have more specific codes than others. So, for example, sickle cell disease has subcategories and also a category for sickle cell trait. Thalassemia, however, only has one code and doesn't distinguish between trait and disease. So a lot of times you're limited with what you can tell just because the codes don't exist. Some of our codes have good identifying information, and some of them don't. Right now, we're talking about certain, instances of healthcare utilization. It takes a little bit more work to associate each of those instances of utilization to an individual. So that can take deduplication very often. So depending on the unique identifiers that you have, that job is going to be sometimes easy, sometimes pretty difficult. So for some of our insurance information does have names and identifiers. The hospital discharges from the Georgia Hospital Association don't have complete identifiers, which makes it a little more tricky to complete the deduplication and linkage to our cases. So even with some of the challenges we had, we were still able to use this information. Maybe not so much for the confirmed case identification, but certainly to describe more of the scenario around that case and the utilization of that case. So we've been able to characterize healthcare use by county, also vastly improve our estimates of prevalence of disease by age, sex, somewhat by race, ethnicity, and certainly by age. This is before this project and before this study, we just used estimates of disease, prevalence estimates from other studies, and now we have our own estimates that we can divide geographically. And they were geographically across the state, they were different. So we were able to inform our local clinics and also our direct patient care organizations with prevalence information specific to the people that live around there and directly for the people that they care for. So additionally, with additional funding, additional work on this, we'll be able to validate the case definition and potentially do more surveillance beyond 2008, and also work on health promotion pieces. and evaluate potential health solutions. So take it one step from just having a prevalence estimate, but now work on informing patients with sickle cell disease and other hemoglobinopathies and their families. So I guess in summary, we've been able to advance the knowledge of the health service use in the sickle cell disease population, and this information can, and this process also can be used for other lifespan conditions, birth defects and all other chronic diseases as well. Next slide, please. So thank you very much for this opportunity, and I wish to thank the rest of the members of the RusH Collaborative in Georgia. Thank you.
Thank you, Brandon. All right, and next we'll have Lisa Pugh from Florida, and she'll be introducing creating a physician reporting website. Lisa, if you can press *6 to unmute your line and address the audience.
Hello, I'm Lisa Pugh. Can you hear me?
Yes, we can.
Okay. Again, I'm Lisa Pugh. I'm the project coordinator for the University of South Florida and the University of Miami. Okay. In creating a physician reporting website, it allows physicians to submit demographic, clinical, and laboratory-confirmed sickle cell disease and thalassemia patient information. It also aids in case confirmation and linking data from other sources. There are several key resources that we found. You need to have an experienced web designer, and you also have to be able to have discussions with staff that are knowledgeable in health informatics, record linkage, and epidemiology. And you also have to have discussions with physicians. You need a list of physicians and clinicians with high volumes of patients. And one of the things that we also noticed is once we offered financial incentives, they were giving $25 per verified record entry. Our lessons learned. We understand that there are challenges of physician practices that are busy. So what we did was we identified a dedicated staff at the office to enter the data. Next slide. Our first data entry began April of this year. And within 48 hours, we had 120 inputs. The sustainability. Cases can be shared with the reporting physician, and aggregate data can be shared with all physicians. The translation is unlikely to continue without continued funding. And since our last document, we have over 500 records submitted to our website. So we have reached out to 123 physicians within the state of Florida. Next slide. So today we have 559 patients that have been entered, and they come from single adult and pediatric hematologists, oncologists. And this report, we got this information from our website, which is through RedCap. Next slide.
So we did move on to the next slide, but there might be a time delay because of the graphics.
Okay. So what you're looking at is our secure site, which we send the physician's offices information on how to create an ID so that they'll be able to log into RedCap. Next slide. Okay, and this slide shows the information that the physicians receive once they've gotten the obtained ID of that the information that they're submitting, and it's private, and they're the only ones that are entering the information. Next slide. And this is also some information about RedCap. Next slide. Now, this is our administrator application, which the administrator is Dr. Jordan, and she's the only one that can go into this and you can see the different programs that she's allowed. Next slide. And then also we're able to pull up the different programs that shows the patient gender. Next slide. And this one shows the race. We have the comparison between the different races. Next slide. And that's another one with the different. This one deals with the Hispanic Latino ethnicity. Next slide. Another one with the ethnicity. Next slide. And it shows how we obtain the patient's information, health information. Next slide. And their place of birth. Next slide. So basically, the next couple of slides just illustrates the different thing that we're able to extract. Next slide. From using our database. Questions that we're able to find out as far as patients' knowledge of blood transfusions. Next slide. And our contact information, Mary Beth Vickers is our PI, and Dr. Lynetta Jordan is the second PI. Thank you.
All right. Thank you so much, Lisa. At this point, we can actually open the lines for questions, and please remember to unmute your phone individually by pressing *6 if you have a question, or you can raise your hand electronically, and your names will be called in the order that they're received. We do have to end this call right at 3 o'clock, which is in about 9 minutes, so if you do have any questions, I greatly encourage you to ask them now. Nope, no questions? Okay. Well, I'm sorry. Go ahead.
This is Ying. Can you hear me?
Yes, we can. Hi, Ying.
Oh, hi. I have a question for Lisa, California. Is Lisa there?
Yes, I'm here.
Hi. I look at your unique case table here, ICD, that slide, and could you explain a little bit more on that? I'm not quite sure. You see, the second column is cases found, and then the last column cases unique to data source.
Sure. Well, basically, the first column of cases found is what it is. It's the total unique individuals found within each data source. So for 5 years of newborn screening, we have about 1,000 cases that were picked up through newborn screening, so about 200 cases a year. In between the two clinics, we found 1,000 cases.
So what a year period for those clinics?
Pardon me?
What a year period, the service year or something?
No, this is just combined over the 5-year
5 years.
5-year period. I mean, it's not, with newborn screening, we went back even further in time because we knew those babies were born with a diagnosis, and many of them were actually being seen at the clinic during the period 2004 to 2008. The inpatient hospitalization, for example, we found almost 4,000 unique individuals. So you can't simply add up all these cases and come up with a determination of, if you added them all up, you're over 10,000 cases. But the duplication across these data sets, that's the point. And so I thought it would be helpful to demonstrate the unique cases that were found, meaning that cases that were found unique to that data source, not seen elsewhere. And it just gives you a sense of the utility of the data source. For example, the emergency department records, only 32 cases were picked up that were unique to that data source. But you can see there's almost 3,000 cases. So there's a huge overlap between emergency department data and cases identified through other data sources. You almost need like a Venn diagram to really show all the overlap between all the different data sources.
Okay, I see. The last column, actually, they are exclusive from each other for the multiple sources.
Yes.
Okay, I see.
In total, and it's not shown here, there were just under 6,000, 5,000.
Yeah, I saw in the previous slide, 5,800.
So that's the bottom denominator. So that's just the certain and probable cases. Doesn't count what were really lots and lots, thousands others of what we called the possible cases. And so anyway, I hope that is a clear explanation.
Yes, clear. Thank you, Lisa.
Okay, are there any other questions? All right, I don't believe there are. Well, this session concludes the 2012 webinar series on hemoglobinopathies. I want to thank all the presenters for providing their slides and providing their contact information for follow-up. Thank you to the listening audience for joining us. If you currently receive the email updates about the series, you will be receiving a survey in the next couple of weeks. And by completing that survey, you'll provide valuable feedback for our presenters and our organizers. Lastly, you can look forward to a save-the-date email with the agenda for the 2013 webinar series. If you have any questions, feel free to contact me, Shay Pope, at spope@cdc.gov. The recorded webinars are made available through scinfo.org under the webinars toolbar, and it will take us a few weeks to get this one archived. I believe the webinar from last month isn't quite up yet. But thank you all again for participating, and I hope everyone has a fantastic day.